And so it's just appropriate for us as the MIM, at least to talk a little bit about the strategies, our own perspectives on the programmatic challenges of towards elimination. And so today we have 4 speakers who will go from malaria case management, the tools for malaria elimination, vector control, and then an overall malaria elimination within universal health coverage. So we'll cover those. And I'll just hand over here to the backbone of the MIM, Professor Mbacham, who will take us through these presentations. Thank you.
The first presenter is Professor Marielle Bouyou Akotet, make sure you take the podium, who is a professor in the Department of Parasitology and Mycology, the Tropical Medicine at the University of Sciences de la Santé in Gabon.
Thank you. Good afternoon. I would like first to thank the organizing committee to give me the opportunity to share with you an overview of programmatic challenges in malaria case management in public and private sectors, and to have a look on some intervention to overcome it. Indeed, despite a substantial decrease of malaria morbidity in Africa, stagnation or rebound are observed in several countries, and even in the 10 high burden countries of Africa, an increase of more than 3 million cases has been observed. Morbidities remain high. It is suggested that this continuous morbidity could be partly explained by 2 problems in the system: the availability of services, and also the fact that people do not have access to these services even when they are available. Indeed, more than 30% of febrile children do not have any medical care for their febrile illness in Africa. Only 36% are brought to care in public health sectors, and less than 10% in private ones. But this was not the pictures in 2010, when public and private service share the same proportion of frequentation. And since 2013, febrile patients more frequently have more frequent access to public sectors. In this public health facility or in the community, those which are diagnosed for malaria receive now SCT in 80% of cases. This is not the case in informal and even formal private sectors. This private sector represents an important part of the anti-malarial market in several settings of Africa, and is represented by any facility, outlet, or individual that provide malaria care, dispense anti-malarial drugs, but are not managed by the government. The Case Management Working Group of the World Bank Malaria have pointed out the necessity to engage with private providers on the reporting of all malaria cases and effective case management and follow-up, as they represent a major source of healthcare, and to improve the programmatic case management of these diseases. And they also pointed out 3 established work streams during their last meeting in February: access to case management, quality of its case management service, and the delivery of its services. Concerning the first point, patient care seeking is one of the key components. 10 national malaria control programs who participated to the meeting of the Case Management Working Group highlighted that patient behavior unfaithful diagnosis result, poor knowledge of malaria symptoms, poor access to diagnosis and treatment, and also preference for seeking care in private sectors were major issues for programmatic case management in Africa. And in a study performed in Ghana, it was observed that patients preferentially sought care in public health sectors. And I don't know if I can use it now. Young age, severe malaria, delay fever, and even poor people with low income were more frequently accessing public health centers. This was not the case in another study in Ghana, again in another city, where the majority of patients attended chemical shops. Even those who attended public health center were first in chemical shops. And in Uganda, in the result from the ACT Watt Research Project highlighted that most of the patients in private sector had self-antimalarial medication, and these drugs were dispensed in private sector, mostly on drug shops. It is important to notice that when we confirm malaria prevalence in care-seeking patients interviewed in private sectors, malaria prevalence is always low, below 20% in those attending private shops or structures, and is always high in those attending public health structures. This was observed in Nigeria and Ghana. Health workers are also key component of the quality of case management service and delivery of service. Again, the 10 national control programmers highlighted that bad behavior, presumptive treatment, lack of training, supervision, refresh of training, bad knowledge on recommendation, shortage of qualified health workers, and lack of diagnosis capacities were also major concern for case management of malaria. Again, concerning the malaria diagnosis, we can observe here that most of patients seen in public health sector do not benefit from diagnosis. But when this diagnosis is performed, RDT are most often used. But also, another issue is the presumptive treatment of malaria, which is the rule, which remains the rule in health facility areas, also in private sectors. ACT treatment and malaria microscopic diagnosis or RDT diagnosis is often performed in less than 20% of cases. This was also observed in a study performed in Malawi, where only 23% of patients benefit from correct diagnosis and appropriate treatment. When we have a look on the quality of ACT prescribed, quality assured ACT were prescribed in only less than 50% of cases, as reported again by the ACT group, either when the test was performed or not, and even when malaria test is negative. The same observation was done in Cameroon, as you can see in this slide. There are limited data concerning care management in pregnant women, but you can see in this slide that knowledge is always good, but we can see here that less than 70% know that on private sector know that SP is the recommended drug for IPTP-SP, and they accept to use it, and the timely dosing of SP as well as direct observation, most frequently in private structure. Access to commodity is also of concern regarding case management. It concerns availability and use of SCT and malaria diagnosis, most RDTs. In public structure, SCT are the main anti-malarial prescribed. This is not the case in private sector where non-SCT, even chloroquine, are still prescribed. But it is important to notice that anti-malarial drugs are provided by the government in most of the public health structure, while it is purchased from the market in private sectors. This report from SCT Watch also highlighted that in several countries, the private sector is less provided with malaria tests. It is the same also for the ability of qualified SCTs. And we can see in this picture that oral quinine, non-artemisinin therapy, injectable quinine, and SCT are still prescribed in private and public health facilities. I cannot finish to talk about drugs without just citing counterfeit SCTs. The 10 national control programs are participating to the working group also highlighted that absence of communication between programs, health worker, academic, the type of transmission of important information, the absence of data report of private sectors, and the absence of their inclusion in program, reduction of funds, and the limited access of patients to case management tools in rural areas are also of main concern. Some interventions are proposed to overcome these challenges. They include training of health workers from private sectors. This training allows to increase the testing and also the correct treatment of patients. Also, subsidizing SCT combination therapy in private retail, which was shown to improve the use and availability of SCT, but also to allow reduced price, improve market share, and reduce use of older anti-malarial drugs, as showed by this Cochrane meta-analysis. Other directions are action in community, drug shop, and health facility through sensitization to change in diagnostic policies, training of everybody, and close support and supervision. I would like to finish with the 3 next slides just to show you that the ALMA also had direction to further consideration in intervention toward malaria elimination through some action like establishing an elimination council and developing national malaria control program and elimination scorecard in every malaria endemic country, supporting and happy to scale up new intervention, and supporting innovation financing, which is important. Also for RDT-based planning, training, build trust in malaria RDTs, guidance, and affordability of medical supplies are proposed. And the working group of rollback malaria also highlighted that ensuring only good quality anti-malarial medicine in private provider, good quality diagnostic, availability and affordability of quality assured anti-malarial, improved case management by private provider, and improve also malaria surveillance, both in public and private sectors, which allow us to attain our goal. So the take-home message is that better malaria case management involves improving all the components of health systems. Thank you for your attention.
Thank you very much.